And really, teledermatology was one of the founding specialties of modern telemedicine. And it really can be used as a model. It has really been used since the 1990s, actually. And in around 2000, the military started making really broad use of it. And this is actually a picture. It has often been used for demonstrations of how telemedicine can work really before telemedicine became what it is today. And so we still do those presentations, and GP Track uh, sponsors one of those. And so this is me actually doing the Telederm demonstration this year at the State Fair. And you can see in the University of Minnesota State Fair booth there. And this is Zoe's elbow, who is another member of GP Track. So um, dermatology is a nice model for a series of reasons, in that dermatology is a highly visual specialty, and we really do have a lot of people who are interested in technology and interested in being adopters. And we don't have enough dermatologists, so trying to figure out how to bring our knowledge to people in lots of different ways to help people has really been an ongoing interest for a long time. So sort of early on, like the barrier was primarily technology. So like in my pediatrics residency, we had actual physical digital cameras that were in lock boxes in a couple of places in the hospital. And they actually it was very cutting edge because we managed to actually connect it into the EMR. So a distant dermatologist could take a view of something that was going on like in the emergency room. Um, from the photographs, video at that time was early on, and then later still pretty slow and grainy. You just don't, and even now, viewing skin over video is pretty limited, and so that is why photographs are so important. And cameras used to be of lower quality, and uploading pictures is more of a challenge. And so eventually, tech caught up, as we all know. We all now walk around with our smart devices in our hands, taking pictures, thousands of pictures all day long of all kinds of things, and uh, so that had been really cracked that open. And so then it was like a little Wild West for a while. And so there were a lot of sort of direct to consumer telemedicine websites, and these are, a little bit black boxy. And so they did this sort of cool secret shopper thing where they sent um, pictures of different rashes into one of these websites and tried to see, kind of all kinds of things, acne and psoriasis and so on. And tried to kind of see what was it like. And they missed and in the sort of direct to consumer, you don't know really who's treating you types of situations. They had repeatedly missed diagnoses that really mattered, including secondary syphilis, eczema herpeticum, which is a really dangerously infected eczema, and some other important systemic diseases. And treatments prescribed were sometimes at odds with the existing guidelines. So a little Wild West for a while there. And then, so there was some slow uptake and progress, with payment and administrative barriers. And then pandemic suddenly moved everything forward and really, really fast. And so, what's the future? And I would say if you look back to, you know, the 1980s, the 1990s, you kind of think it's hard to imagine what life was like before we all had a smart, computer in our hand. So where are we going? And I would say it's probably something we have not fully imagined yet. I'm very excited about the day where somebody's going to just scan me with like a tricorder and fix whatever horrible problem I'm having. But this is what's in our future, and I don't have a crystal ball, neither the rest of us, but I'm talking about some options and things. So challenges that we face, right? Money, a fair amount of what is considered the right way to deliver care is really hung up on like what do we get paid for? So the questions are often not asked as to like forwards, but often backwards. What does like whatever administrative rule really mean? What is the quote unquote right way? Like what is better? Let's not let the perfect be the enemy of the good, but also let's make sure that we're delivering high quality care and not missing syphilis. Who, what, where, which diseases, who to trust, and many, many questions out there. But there are like so many opportunities, and so many questions to ponder. Why are we all building the same answers over and over again? I worked in multiple different systems, and they are all trying to build like the same e-consult thing over and over and over again instead of just, I mean, it exists in Epic and another hospital. Why are we not just sharing that information? I don't know. Um, how do we make tech work with us to care for people instead of against us? How do we stay agile and adaptable? What's privacy look like in the modern age? How does move fast and break things culture of tech apply when things is actually people? Like you need to be, right? So it's a different calculus. And then really, how do we distribute people and knowledge to the right places and right times? And what is a right place and a right time? And how do we see the same big picture, right? And, am I still hungry or just not let my lunch still yet? All these questions. So back to dermatology as a model. So a lot of people see dermatology. I don't know if anybody's old enough to remember this Grey's Anatomy um, uh, thing about dermatologists. So the dermatologist is getting a hand massage and they're drinking raspberry water, and they're showing this in sharp contrast to the surgeons who are doing their real work of medicine. And the question is like, does access to dermatology matter? If we're going to use it as a model, like why do people care about it? And a variety of reasons why people care about dermatology, but one, in fact, people actually die more and sooner without access to dermatologists. So if you look in rural areas, if you look at counties with no dermatologist, even having a little bit of a dermatologist decreases your melanoma mortality rate from between 35 to 53%. And so the cutoff for that, if you look at this map, is actually this color. So if you are a lighter color than this, you are in a place where you are less likely to die of melanoma. But if you are in these darker ranges at all, you are significantly more likely to die of your melanoma. And the one thing I did want to bring about this is that we talk about this as though the rural areas are only in the middle of the country, but actually, if you look, it's scattered all over. So, patients with a dermatologist compared to non-dermatologist physicians were diagnosed with melanomas at lower associated stages, Breslow death, cancer-related mortalities. And what's interesting is that the Breslow depth actually increased a little bit by each 1 mile increase in distance travel to a diagnosing dermatologist. So there are a lot of opportunities there. And then there are rare diseases in dermatology. So Merkel cell cancer is a more rare disease. The rural mean area survival is 34 months, and the urban area mean survival is 41 months. And when we're thinking about that in the grand scheme of things, you're like, that's not a lot of months either way. But that's the difference between making it like from this summer to next Christmas. And so that is very impactful in the life of a family. And Merkel cell patients in areas with high density of dermatologists have a 20% greater survival rate than those without. So what about rural kids in derm? I'm a pediatric dermatologist. I don't have a lot of children dying of melanoma, thankfully, because it's a very rare disease in children. But when we're looking at rural kids in dermatology, Medicaid and CHIP really covers 47% of children in small towns and rural areas, and 40% of children in urban counties. And so what they did was they took a look at atopic dermatitis treatment compared between children on Medicaid versus commercial insurance. Um, and this is relevant more because in rural areas, you have more kids who are on Medicaid. And Medicaid patients are 6 times less likely to see a dermatologist for the atopic dermatitis. They were less likely to be prescribed topical steroids and calcineurin inhibitors, which are the standard of care and have been for many years. And they are 3 times more likely to be prescribed antihistamines for their atopic dermatitis, which does not actually treat atopic dermatitis. And so it does contribute to significant gaps in care. You say, well, maybe we can get them to more pediatric dermatologists. Well, there are 400 pediatric dermatologists in the US. And the numbers in a given state really don't reflect the complexities of distance, insurance, and referral patterns. So if you look at the colors of this map, darker is more pediatric dermatologists. You think, oh, Wyoming's doing great. But there is one pediatric dermatologist in the state of Wyoming. There are zero in the white ones. And while Minnesota, you're like, oh, Minnesota's doing great. It's dark blue. Well, that's true. There are 11 pediatric dermatologists in Minnesota. However, they are concentrated in the Twin Cities and Rochester. And so for the entire top of the state, so a 4.5 to 6 hour drive from a pediatric dermatologist, they essentially don't have access. And this is true not only of pediatric dermatology, but this is pediatric subspecialty care across the board. So this is estimated driving distances on the top to a pediatric rheumatologist and a pediatric hemonc. And then the bottom is looking at the pediatric rheumatologist per 100,000 children on the left, and then pediatric hematologist per 100,000 children on the right. And so we really have a lot of uh, gaps in pediatric subspecialty care in huge parts of the country. So pediatric dermatology can be a great model place to start because with derm, our tech can be a little bit lower, a little more accessible, and you can get very fancy with the technologies that are available. There are these really cool telecarts that I had a colleague who was doing consults at a rural hospital where literally they would flip on the cart, he would drive it to an elevator. You have to ask somebody to press the button for him, but then would drive to the patient's room and be able to have a really good visualization of what was going on in the patient's skin, talk to the family, talk to the nurse, and a lot of the diagnoses can be made with that and a little combination of still photographs. While biopsies are sometimes necessary, those can actually typically be done by other specialties. You really need a dermatologist to tell you what to think about and where to biopsy. And telecarts have a ton of power. One of the places that I work actually runs their cystic fibrosis and interstitial lung disease program, primarily by a doctor who actually lives in a different state who had been at the hospital previously, and uses these telecarts with a with an MA to assist, and if so, if they can be taking care of. The pulmonary complications of interstitial lung disease in children, I think we can manage a few rashes. So, let's talk a little bit about sort of different ways teledermatology has been used. So, rare disease. So, dermatology is a land of, in most parts, as in most parts of medicine, there are a lot of common diseases, things we see frequently, and then there are rare diseases. And one of the groups of rare diseases we have is a set of diseases called ichthyoses. And the individual ichthyoses are can be quite rare, as rare as 1 to 200,000, 1 to 300,000, 1 in a million. And so, because of the rarity of these diseases, back in 2009, a telemedicine consult service was set up through the patient advocacy group for people with ichthyosis. So, the group that the first, which is the Foundation for Ichthyosis and Related Skin Types, began offering physician to physician consults so that people who were not experts in ichthyosis could then get guidance from the experts who were often on the medical scientific advisory board of this group. So it was a nice combination. And what was nice is that patients who found this group would have the support of the group, of the other families affected, of the staff, and all of that combined expertise. But then every once in a while, their doctor would need to ask a specific type of question. And so we analyzed the data from cases that were submitted from 2009 to 16 through that service. And that was a whole volunteer service. And so the submitter demographics ranged from dermatologists. And so even other pediatric dermatologists would need to ask the experts in this category of diseases. And then a lot of folks outside of dermatology, we sort of looked at all the different places that people were asking questions from. And were they residents and fellows, or were they medical students? Were they other disciplines? Really, who was asking some of these questions? We looked at where the cases were coming from, and primarily, as this was a U.S. based patient advocacy group, the majority were from the United States, but they came from really all over the world. And the organ system that they were asking, the people were asking questions about, was not necessarily just skin, but a series of questions were asked about other aspects of people's healthcare relative to these rare diseases. So, and in the vast majority of cases, useful answers were able to be provided. So, fast forward to recent times, and the next sort of issue is that now with the now that the internet is broader, more available, people are comfortable with the concept of telemedicine, we actually are dealing with the fact that a lot of folks want to ask the experts directly because for many of them, they cannot get their doctor, their nurse practitioner, whomever, to contact this service to help ask their questions. And we say, oh, we should all go through primary care. But if you've tried to get a primary care doctor recently, we know that there is the healthcare crisis is real. Um, and so what sort of the take home here is that telemedicine is completely possible for rare diseases. And we can actually bring the expertise of all kinds of groups of these centers can be available actually fairly broadly. And it really comes down to the barriers of licensing, of time, of payment, but that it is possible. It has been proven that we can help with this. And then, a lot of some of these kiddos are, when they're born, have a lot of needs immediately at birth. And they are in the NICU, and the NICU doesn't know what to do. And so the NICU will reach out to their local dermatologist, and every once in a while they know to reach out. Somebody starts working their network and will reach out and get in touch with this. But this is still being done really in old school ways via texting, via email, when we could have a more formalized process. Hard to have one small hospital or one even moderate sized hospital be or even this panel of experts be sort of on call for this. But if you combine this, the whole, if you combined all the people in the U.S. Who are able to take care of children with this disease and provide you this information, we actually could be doing a lot better. Um, so again, this is just one published example. Epidermolysis bullosa is another group of rare diseases in dermatology that is a rare skin blistering disorder that has a lot of systemic issues associated. And there are centers in the U.S. for these diseases, but essentially due to licensing, billing, administrative barriers, the use of teledermatology from those centers to these kids in other places is really very limited. And so, really, there is huge lost opportunity for rare disease populations. But I think that if we start to think about could we use dermatology as a model to start piloting things to start to figure out how do these payments work? How would this work? I think there's a lot of opportunity there. So, moving on, let's talk a little bit about telespecialty care generally. So, pediatric dermatology in terms of access. There are practices like mine where I work directly with patients. I'm a cash-based model primarily. I am licensed across the upper Midwest. If you have a child with a skin problem, I am happy to see you, and we do that. Health systems can serve large rural areas, so I also work part-time remotely for a children's hospital in rural Michigan, and I do telederm for them. And most of those patients are hours and hours from their hospital. We do some inpatient as well. There are these sort of large telemedicine direct-to-consumer practices where you don't know who you're seeing, if they're a dermatologist or not. Minimal supervision. I do not recommend those for the reasons we talked about before. Um, but lots of people are using them. Hair loss is a huge industry. Acne is a huge industry. And then there's some limited primary care that's definitely doing it right. There are probably others, but I like to call out Blueberry Pediatrics because they are board certified pediatricians. They are taking care of children with all kinds of sort of urgent type of problems, sort of minor urgent type of problems. And they actually have like at-home strep tests and they have otoscopes that go on mobile devices. So you can truly actually diagnose strep throat or an ear infection or something appropriately and at a high quality level of care. And I think that one of the things that we need to keep in mind is that there is quality to be considered and that we can do this well if we want to. So, in terms of access, e-consults are basically a store and forward. So you take a picture, you write in a little history, you send that off to a dermatologist, and then like a couple days later, you get an answer back. So this has been used all over the world. There are many, many examples. It has been widely used in the U.S. The VA has a really strong program in it, but I just love this one because it's a mobile teledermatology was being used back in like 2015 in rural care in Mongolia. And so they were actually getting people to the right places and they were actually getting more diagnoses for people. So e-consults are great in the implementation. You know, devil's in the details. So I'm on this WhatsApp group with a big bunch of dermatologists, another big health system that I used to belong to, and they got into a very long discussion about e-consults, and they can get 30 to 50 per day for the on-call person and the reimbursement. And so we cannot forget that how things are paid for really affects what people say is possible when we're talking about teledermatology or telesolutions in general. Store and forward teledermatology with clinical history works in that. So that can be from a doctor or from, another provider or an APP, but also can actually be directly from a patient. So they studied this at the VA, and experienced teledermatologists were able to make a clinical decision in 95% of direct to patient store and forward cases. So patient sent in a picture and they didn't even give them instructions on how to take pictures, and um, only 1.9% of cases required an in-person visit because the image was not good enough. And then they did a similar, very small study at teledermatology visits from Children's Hospital of Philadelphia, and they used parent-submitted photographs. And they actually, these are ones where they actually had kids seen in person uh, to verify diagnosis, and they had really had a nearly 89% diagnostic concordance. So let's take that to the next level. So, okay, we all have a smartphone, we can take pictures, whatever. So, well, if those pediatricians are using otoscopes, can we be using dermoscopy, in the clinic to give? So, say you are in a rural area, and this is what this work was done in Maine by Vinnie Seiberling at a large rural practices across the upper across rural Maine, and so they actually trained primary care how to use dermoscopy, which is essentially like a an advanced tool for looking through the top layers of the skin that can give you more accurate diagnoses for melanoma or not. They taught workshops, and then you could join their monthly echo telementoring sessions, and they provided dermatoscopes. And the number of moles biopsied to detect one melanoma decreased from 34 to 11.3 following this training intervention. And so it really does affect the quality of care that people are getting to be able to put knowledge in the hands of the people that need the information and really at the front lines. They then used store and forward consults with teledermoscopy, and this was done in Europe, and found out that dermoscopy does, in fact, help in that scenario as well. So the teledermoscopy led to a reduction of unnecessary referrals for people who had benign skin lesions. And then this is another example out of that rural health system. So you have this child, a young child. So back to my bread and butter. What about little kids? So you have this mole that from that picture, it looks a little funny. I agree. It looks a little funny. It's not exactly all the same color. Melanomas in children are rare, but not zero. And then when you look at it under dermoscopy, when I see this picture, this tells me that this area of this mole is perfect. These little hairs are healthy, normal, happy. And we're able to say this is just a normal growing mole. As you are growing, your moles are growing, and we have no concerns that this is a skin cancer. Whereas based on this photo alone, there is a higher likelihood that that child would have had to drive some number of hours to be seen. And so then stepping it up to the next level, can you do dermoscopy at home? And does it have to be tech savvy people? It turns out no. So they did this really cool study where they actually sent a bunch of veterans who were being seen for skin cancers at the VA in San Francisco, and they actually they sent dermatoscopes to them and let them take pictures of their own skin and spots that they were worried about. And in fact, they were able to do a great job taking the pictures. They could diagnose them, and then they did see the people for in-person diagnostic concordance. And so, if elderly veterans can do their own dermoscopy images, I think there's a lot of possibilities for us to be able to roll these technologies out broadly. So, rural access to treatments, right? So we're talking about patients that I see. I have patients I take care of that are, 4 hours from my location in Minnesota. I have patients that I take care of that are 8 hours from the Children's Hospital in Grand Rapids, where I take care of them. And there are therapies that we can do at home now. Biologic therapy, which are injectable medications, have really revolutionized dermatology. And so these children actually can largely be taken care of at home, outside of the office, outside of the hospital, because of the advent of these medications. And we can prescribe them via teledermatology in these visits with conversations. Families can go see a nurse to do training, but they actually can even do training online for how to give them medications, which are injectable. we can support this fully with tech. However, biologics aren't the cure for everybody. And so, one of the, as with many therapies, this is an example in dermatology of a therapy that we typically would do actually in specialized treatment centers around the country. And it's called Geckerman therapy. And it's actually a combination of tar, which is up on the picture there. It's the black stuff. It really is a tar. And that is applied to the skin. The patient then goes into a light box, and I have an example of what these light boxes look like. You actually go in typically with no clothes on to wherever the rash is on your body. These are nurses who are standing outside and running the light boxes, making sure people get the right length of therapy, are there if you need help. And then you sit with this medication on your skin for most of the day, and you see they cover the chairs and everything because they are covered in tar. And this is a great treatment. You can actually put people's skin into remission for up to 3 to 5 years or longer sometimes with a course of Geckerman therapy, which usually requires about 25, so about a month worth of 20 to 25 days of in-office, essentially all day therapy. So, turns out this company, Soleil, is working on being able to do this at home, as Geckerman centers are actually closing around the country, primarily due to low reimbursement and with the advent of biologic medicines. They actually are trying to figure out how you can do Geckerman therapy at home. And so they have a nurse that guides you through application. The medicines can be sent to you. And then these are just examples of home light panels that you can get. So you don't need to have the giant um, box in your home. You can actually have these and they fold up nicely against the wall. You can do home phototherapy ongoing, or you can do home Geckerman therapy, which would be a shorter course, put your disease into remission, and then go forward from there. So, if we think outside the box, literally outside the box, outside our walls, there are a lot of things that we can do. And this is actually also a very cost-effective therapy, especially if done at home. And also then people don't have to miss work. So now with remote work, you can actually do Geckerman therapy at home and also manage it into your life. And then, so thinking otherwise, so what are other things that rural folks are missing out on? Like they're missing sort of the access to these more intensive, time intensive treatments. But they're also missing out on clinical trials. So this is a map of hidradenitis suppurativa specialty clinics. This is a terrible disease, which essentially gives you um, uh, kind of like the worst acne that you can imagine in your armpits, groin, buttocks are the most commonly affected areas. And it is a hugely disabling disease and is typically managed with a combination of medications and surgery and antibiotics and other treatments. And the purple is where there are specialty clinics. And so a lot of these people are getting now more into clinical trials because there are better and better medications coming down that are now available. So, for the people who live out in these not purple states, really hard to get into clinical trials. Even the specialty centers don't all do clinical trials. And traditional trials, right, are you have a primary and guest investigator, you have the site, you have all the people, sort of built in, and that's how the trials are run. Well, so now, and this is just one of the companies that's doing virtual trials, but trials can actually be done, and we call them more decentralized. So you have sort of the home base, which can be anywhere. And then all of that is pushed out either to a local site or actually to people in their home and then coordinated with lab visits. And this has been going on conceptually for a long time. So this was Pfizer tried to do a trial back in 2011, and that at that time they were having trouble with recruiting people because they were having trouble with the technology and how to use digital health tech in a trial and so on and so forth. Well, um, post, this many years later in post-pandemic, as we all know, proven by the vets, older folks can use technologies just fine. So virtual clinical trials have been run in pediatric dermatology and very practical ones, even emollients to, which is moisturizers to prevent pediatric eczema. And this was a trial that was done, 25 community-based pediatric and family medicine clinics that are members of 4 statewide practices, and they were actually able to do this over a series of years completely remotely. And then tech is really stepping up. And so these are all devices that are used to measure how much people are scratching in atopic dermatitis as part of atopic dermatitis trials. And these can be mailed to you. So, however, you need to be thoughtful about all of these things. And so, in the sort of challenges and opportunities, they looked at rural clinical trial participant perspectives on um, the values, health behaviors, motivations for enrollment and retention in clinical trials in remote settings, and really did start to explore some of the themes there. And so, addressing these themes, thinking about this type of information, looking for this type of information is really important to bridge that gap. So when we're trying to bridge a tech gap and bring it to any area, be it an urban area, be it remote, be it rural areas, we need to be uh, talking with the people there and figuring out kind of what exactly their problems are, what their concerns are, and where in the trust and community partnership lies in order to bring healthcare up for that whole area and to make things available like clinical trials. Uh, so I think the other thing that we've been thinking about a lot is that people no longer access their health care really in the exact same way they used to, especially with less common diseases or if they feel like their needs aren't being met. And so people are accessing care more and more and more, essentially through social media. And so many people will find the patient advocacy groups that I mentioned actually through their own social media searches. This is Camp Discovery. And so access to dermatologists is enough of a barrier to get referred with a serious skin disease to free camp. We have a free camp that we do for kids with skin disease that we actually went to parent referrals this year because we know that we can advertise that on social media and then parents can refer their own children for this skin camp. The way that the world is being the world is changing is not lost on us, and we need to be thinking a little more broadly about how people are going to be accessing their health care and all of the pieces of their health care um, in various ways. Social media, also, right? Another place. So we actually, medical student that I worked with, we actually looked at the information out on TikTok for various rare diseases and sort of who was providing it and what was out there. And so there were youth run accounts that were posting videos about disease education and awareness, typically of affected persons. And then parent run accounts of affected people were posting more videos related to support being the parent of someone affected with one of these diseases. A lot of the comments were demonstrating a lot of positive engagement. Obviously, you can hide various comments, and we think that's absolutely appropriate. And this can be a place to spread awareness and gender a sense of community and create a space for self-oppression for people, self-expression with rare diseases. And this is something where there's the positive side, social media as well. So there are a lot of concerns about teens using social media and the harms it can cause. And then also on the flip side, there are positives. And again, we talked about the patient advocacy groups that do exist through Facebook and Instagram. And they're starting a teen Instagram group, for example, through First. And then the other thing that I like to observe about social media is that it is a conduit for information, not only for patients, but for other people. So back when I was on Facebook, I've been off it for since about 2017, but um, there's a group on there of physician parents, physician mothers, and there was an infant that had harlequin ichthyosis, which is the very most really serious kind of ichthyosis, where babies, if they're not properly treated, will typically die within the first, days to weeks of life. And so they were able to get this child quickly to a hospital that could treat them appropriately. I personally had a physician mom who found me through one of these groups. People said, she asked, where do I take my kid for this spot? And it was sent to me because I was local to her. There's a group called Board Certified Dermatologists, which shares practice tips, but shares complex patient cases for discussion. So if the information conduits are there, they will be used and they need to be used. And then also, we actually, and I'm an advisor to this app called Advice, which is a currently used by the Society for Pediatric Dermatology, among other groups. And essentially, you can ask a question of other pediatric dermatologists in the society. It's replaced an old forum that we used to have, um, and get opinions and help on that. And we do that typically, obviously, with our patients' consent. And then the first platform for the teleichthyosis that I was describing actually has moved over to this. And as I said, I'm an advisor just to sort of the use of this, how we're using the app and its user function, things like that. And then in terms of sort of I imagine very familiar to this audience, are really using technology, teledermatology, and education. So, in order to get subspecialty care, especially for children in rural areas, you have to one, train pediatricians. And so, when you train pediatricians, they we did a survey of pediatric residency program directors, so the people who are training them, and they said that only 6% of pediatric residency program directors felt that the people they trained received very adequate training in dermatology, and a full quarter felt that their residents received inadequate training. And so the rest of people are kind of in the middle where it's probably good enough. And why does that matter? And really, 30% of pediatric primary care visits are for a primary skin problem. So if a full third of the people that you are going to see in your office are for a skin problem, and only 6% of the graduating pediatricians we think are adequately trained to take care of a skin problem, we have a really big gap there. And so, how can we use technology to bridge that gap? So, we have all the ways that I've talked about before in terms of rare disease, in terms of dermoscopy, in terms of e-consult. These are all ways to help. And then this are two scholarship programs, essentially the through the American Academy of Pediatrics section on dermatology. One is a visiting, virtual visiting professorship, and one is in person. And so the visiting professorship funds a pediatric dermatologist to work with a pediatrics residency and deliver either about 5 lectures, either in person over a 1 or 2 day period, or five sort of over the course of a year, to a pediatrics residency that does not have pediatric dermatology access or support. And I have done this in the past. I'm actually doing it again this year. And the what we know is helping is that when the program directors give us feedback, we actually their dermatology board scores will go up for the years that their residents were exposed um, the to the intervention or to the professorship. Okay, but then so now we have all these people out there. Um, they're practicing clinicians. They've missed their sort of window in training of learning about any disease, but in dermatology. So what do we do about that? So for those of you who are not familiar with Project Echo, there was a hepatologist in 2003 in New Mexico, and he was the only hepatologist in the state, which is a liver doctor. And there was an 8-month wait for their hepatitis C clinic, and people were dying, and it was very upsetting. And so the hepatitis C team at the main academic site partnered with some willing primary care clinicians, and they would do a 10-minute lecture, and then each primary care doctor would bring a case to discuss. And this was using video technology back in 2003, which is pretty impressive. And what they did was they actually were very smart, and they tracked their outcomes, and they showed that the outcome of primary care clinicians was equal to that of specialists with this level of subspecialty support in treatments of hepatitis C. So this went on to become like a huge expansion over the last 20 years. There's a PBS special about it, which is very interesting. Dr. Aurora does a nice TED talk. And dermatology, again, was a fairly early adopter in this. And so Dr. Karen Edison started the dermatology echo across the entire state of Missouri back in, I think, about 2016. And she really was a champion and pioneer of this and of virtual visits. And she was actually able to show that this saved their state money enough to the point where actually they get funding now from the state to run echoes. And they were able to show they diagnosed 60 melanomas because of echo. And just as another example, they were able to save $12 million by the asthma echo over 3 years. And huge wins in terms of autism diagnosis, for example. So, we can do this in dermatology, we can do this in hepatitis, we can do this in dermatology. What about pediatric dermatology? So, there was a smaller echo done for augmenting primary care confidence and abilities, and it did show that it was effective. And this allows for essentially, this is your tele-echo clinic. You support primary care teams and the patients that are reached with specialty knowledge and expertise versus just one person like myself talking to one patient. And it gives you a logarithmic expansion and capacity to deliver the best practice care for underserved populations. So, I actually run a pediatric dermatology echo through a HRSA grant through the University of Mississippi Medical Center. And they are one of the telehealth centers of excellence. And as we obviously have this huge unmet need that I talked about before, we had strong leadership and grant support through the University of Mississippi Medical Center. And then sustainability is still a bit of a question. There was thought about it may be able to be done through the American Academy of Pediatrics, but with current changes to HRSA, not entirely sure where these grants are going to be. But that said, we also have incorporated rural medical students as part of this project to help build a pipeline for North Dakota. And so the medical students that do help support and do research and attend these in order to bring the information about what we're learning in the administration of the ECHO out to the world are from the University of North Dakota, and they are then using this to bolster their applications also to become dermatologists and return to their states. So this is the first one that I have worked with, Braylon Weber. And so she actually learned about me because I gave a virtual grand rounds at the University of North Dakota and met this medical student, and she was interested and had really limited local mentorship opportunities because they do not have a dermatology program connected with the medical school. And so she actually is applying right now. She has made amazing strides and progress, ended up doing a patch dermatology fellowship, which is a specialized type of fellowship in dermatology. And she does plan to return to North Dakota to practice. And so having local people build over years is really going to help. What we learned about this that was interesting is we were analyzing our echo is that we had good attendance from the upper mid west and west, but we also had people from all kinds of other underserved places, and including other countries, India, Ecuador, Tanzania. And the thing that was also very interesting is that we actually had a really high school nurse attendance. And so, for those of you who are not aware, school nurses are really a special professional group, and they really do provide vital care to rural and impoverished communities. And really, I think have been an under appreciated resource in the care of children because you don't have school nurses when you're taking care of adults. And so, I think people often do not think about them. And when people say we just need to make pediatricians smarter and we'll fix this problem, well, there just aren't that many pediatricians. So this is where the pediatric residencies are, and people tend to practice generally either where they came from or where they trained. And there's a new one in Fargo. They're just in their, let's see where, I think they're just in their second year now. Um, but there are just purely not enough pediatricians to solve these gaps. But then my last sort of plug is that we also are working on the more dermatologists you have scattered across these places, the more we're going to be able to fix these problems, not only in person, but also by expanding tech, expanding education, expanding those notes back to primary care, and really start to make a difference on closing that, gap in deaths from melanoma. And so if you, this is the Real Access to Dermatology Society, it's fairly new. Mary Logue is really the driver behind it, and she is a wonderful dermatologist who is now practicing in South Dakota and did her training in New Mexico. And they also give scholarships to rural medical students and residents who want to be dermatologists. And so one of the other possibilities and places where we are expanding our dermatology. So this is coming to the end of the talk. And I really think it's kind of just the beginning of the story in terms of the power of telemedicine um, to start solving or continue solving um, a lot of these gaps in care in dermatology. Um, we've talked about use of it in rural areas. We've talked about that in treatment. We've talked about that in terms of diagnosis. We've talked about, is that going to be in a healthcare setting? Is that going to be at home? We've talked about a couple of different technologies. There are others out there, including as technology comes along, we can actually use what's called tape stripping, where you apply tape, literally tape to the top of the skin and draw off skin layers. And as the sensitivity and technology improves for that, I think that ultimately we're actually going to get closer and closer to being able to do a little bit of diagnostics in terms of um, uh, risks for skin cancer, among other things, actually from home and with kits that you send in. Um, so a lot of opportunity. So I would say this is the end of the talk, but just the beginning of the story. And I saw this as I was getting ready for this talk, and this is actually the University of Michigan, and they are doing. They have these AI powered mobile clinics, so they're designing. These are not ready for prime time yet, but they essentially have a place where a general practitioner can use these mobile clinics in combination with AI to start working towards analysis and running interpreting tests and performing some procedures similar to specialists. As anybody who knows much about AI right now, we should know that when AI gives you um, wrong answers, it is actually that hallucinating an AI is a feature, not a bug. And so I think we need to be careful about how we use the concept of artificial intelligence versus augmented intelligence, meaning, if you take a picture of somebody's moles and your augmented intelligence can tell the picture, can look and say, these 5 moles are different between the picture I took 6 months ago. Amazing use in medicine. And definitely we should be using tech to make us smarter and better at our jobs. But again, I think it's just a very exciting time in medicine. And I think that teledermatology in particular is really a place um, where we have a lot of opportunity. We actually didn't even get into the fact that you can have virtual dermatopathology now. So you can take your slides and take pictures of them, and then those can be read distantly. They really are exciting, exciting things. And so I would say, in terms of proof of concept, dermatology actually is a really great field, um, given sort of all of the options for ways to care for people. So with that, happy to take any questions.
Dr. Ash, thank you so very much. We don't have any questions posted in Q&A currently, but I'm going to give people a chance to either post in the Q&A tab, or if you prefer to ask it live, raise your hand
Yeah,
on the
people just want to
bottom.
talk to me.
Yep,
I
and
love to talk to people.
I will activate your voice aspect on the Zoom here. So um, I'll pause for a moment while people consider their questions.
And I know this was really much more of a thought experiment, so not sure that we're specifically going to have
Yeah,
questions per se, but
well, and I really appreciated your perspective too on the acknowledgement that teledermatology has been around for a very long time. You mentioned into the 90s, and that's exactly right. um, it's been a while around for a while, but I think it's also fascinating to contemplate the adjustments and the changes that have occurred kind of not only since then, but we're doing a lot of some of the same things, but how vastly different it has become as well. So,
Right. And how much better we're doing them. We
yes.
had the study with the dermoscopy that they did in Maine where they showed that you don't need to biopsy nearly as many moles to actually find a melanoma, which is great, right? Less holes in people, less cost to the healthcare system, less risk for infections, like all those things are wonderful. And that model actually has an AI component in that it actually helps people take the photos in focus. So essentially, AI will simply analyze the photos for focus without changing the photo itself. And so there are, which it sounds like who cares about focus, but focus is probably the most important problem when you're analyzing teledermatology pictures because a blurry picture is a blurry picture. And so it really is again, just the the options that are out there are really amazing, and it's a matter of just figuring out how to ask the questions, I think. Really how to ask the questions.
We do have a question. Um, Thank you for touching on the e-consult documentation module in Epic. How many specialties do you have doing this service, adults and peds?
Oh, right. So, um, I have worked across multiple systems um, uh, that are using e-consults in different ways. And so I do not have a number, but I would say that I have seen places that have really leaned into e-consult and are using it across virtually all of their specialties and others who have really limited it. So, one place I worked was I wouldn't say early, but an early-ish adopter. And so they had rolled it out pretty broadly, even pre-pandemic, actually. And so places that works really well are like endocrinology is great because somebody checks a thyroid and then they're not quite sure what to do. Rheumatology also like things where you have a brief pointed question are really places where it works the best. The one example that I was giving where you are like 30 to 50 consults a day, that is from a very large organization. And that I want to say they have um, something like 50 or 60 dermatologists on staff um, total, and they have something like 750 primary care providers. So it's a really big organization. So and it covers a broad geographic area. So e-consults are very powerful. At another place that I work now is a county safety net hospital. Um, it works very well there. They've been used. I was trained on them actually in dermatology residency at the VA. And so there we were doing e-consults in dermatology. And then we would actually, as dermatologists, e-consult like GI when we had a question about, hepatitis labs or something that we had to check before starting a patient on another medication for their dermatologic condition. So, and Kaiser actually is a great example that has been using e-consults for many years, and they have a very rich history because when you have a system where it's a closed system and you just have a pot of money and you have to take care of your people, that is a highly effective, like cost-effective way to take care of people. Really, the limits to this have been much more about the payment. And so there's some places that won't do them because um, the way the payment comes out, you have to be able to do them sort of efficiently and effectively.
Wonderful. Thank
I don't know if
you.
that answered the question, but
I,
they're super great. You should do them. They're super useful.
yeah, and systems use them, as you said, in varying manners and at varying degrees, and so
Right. Oh, and then specifically as to Epic, so there are what I will say about that is that this is actually something that drives me crazy. Is that I have worked in a place where e-consults were built, and then I worked somewhere else where they had to be built again, and now I'm working in another place where they are now building them again. And every build is local and it's within that organization's IT. And in my opinion, that is crazy making because we know that this exists literally in other forms of Epic. Like I can throw a rock between my building and the next building and hit it. And we are building something from scratch that already exists. So that is sort of, I think, one of our barriers and challenges, and also an opportunity. Like, can we trace that back up to the source and say, hey, we know this exists in like hundreds of different places around the country. Why are we going to build this from the ground up? What have you got?
Yeah, yeah, really great point. Really great point. Well, thank you, Dr. Ash. I really appreciate your time. I really appreciate your experience with teledermatology, and thank you for sharing it with us today.
My absolute pleasure. Everybody have a great rest of your day.
And watch for we will send out this recording shortly. And thank you again for joining us today.